Pneumothorax. Pneumothorax occurs when the partial or visceral pleura is breached and the pleural space is exposed to positive atmospheric pressure. Normally, the pressure in the pleural space is negative or subatmospheric compared to atmospheric pressures. This negative pressure is required to maintain lung inflation. When either pleura is breached, air enters the pleural space and the lung or a portion of it collapses. Types of pneumothorax include simple, traumatic, and tension pneumothorax. Simple pneumothorax. A simple or spontaneous pneumothorax occurs when air enters pleural space through a breach of either the parietal or visceral pleura. Most commonly, this occurs as enters the pleural space through the rupture of a pleb or bronchopleural fistula. BLEP, bleb. A spontaneous pneumothorax may occur in an apparently healthy person in the absence of trauma due to the rupture of an air-filled bleb or blister on the surface of the lung, allowing air from the airways to enter the pleural cavity. It may be associated with diffuse interstitial lung disease and severe emphysema. Traumatic pneumothorax. Traumatic pneumothorax occurs when air escapes from a laceration in the lung itself and enters the pleural space or enters the pleural space through a wound in the chest wall. It can occur with blunt trauma, example rib fractures, or penetrating chest trauma. It may also occur from abdominal trauma, example stab wounds or gunshot wounds to the abdomen, and from diaphragmatic tears. Traumatic pneumothorax may occur with invasive thoracic procedures, example thoracentesis, transbronchial lung biopsy, insertion of the subclavian line, in which the pleura is inadvertently punctured, or with barotrauma from mechanical ventilation. Traumatic pneumothorax resulting from major injury to the chest is often accompanied by hemothorax, collection of blood in the pleural space resulting from torn intercostal vessels, lacerations of the great vessels, and lacerations of the lungs. Often both blood and air are found in the chest cavity. Hemopneumothorax after major trauma. Chest surgery can cause what is classified as a traumatic pneumothorax as a result of the entry into the pleural space and the accumulation of air and fluid in the pleural space. Open pneumothorax is one form of traumatic pneumothorax. It occurs when a wound in the chest wall is large enough to allow air to pass freely in and out of the thoracic cavity with each attempted respiration. Because the rush of air through the hole in the chest wall produces a sucking sound, such injuries are termed sucking chest wounds. In such cases, not only does the lung collapse, but the structure of the mediastinum, heart, and great vessels also shift toward the uninjured side with each inspiration and in the opposite direction with expiration. This is termed mediastinal flutter or swing and it produces serious circulatory problems. Clinical manifestations. The signs and symptoms associated with pneumothorax depending its size and cause. Pain is usually sudden and may be pleuritic. The patient may have only minimal respiratory distress with slight chest discomfort and tachypnea with a small, simple or uncomplicated pneumothorax. If the pneumothorax is large and the lung collapses totally, acute respiratory distress occurs. The patient is anxious, has dyspnea and air hunger, has increased use of the accessory muscles, and may develop central cyanosis from severe hypoxemia. Severe chest pain may occur accompanied by tachypnea, decreased movement of the affected side of the thorax, a tympanic sound on percussion on the chest wall, and decreased or absent breath sounds and tactile fremitus on the affected side. Medical management. Medical management of the pneumothorax depends on its cause and severity. The goal of treatment is to evacuate the air or blood from the pleural space. A small chest tube, 28 French, is inserted near the second intercostal space. The space is used because it is the thinnest part of the chest wall. Minimizes the danger of contacting the thoracic nerve and leaves a less visible scar. If the patient also has a pneumothorax, a large diameter chest tube, 32 French, or greater is inserted, usually the fourth or fifth intercostal space at the mid-axillary line. The tube is directed posteriorly to drain the fluid or air. Once the chest tube or tubes are inserted and the suction is applied, usually 20 mm of mercury suction, effective decompression of the pleural cavity, that is drainage of blood and air occurs. If an excessive amount of blood enters the chest tube in a relatively short period, an autotransfusion may be needed. This technique involves taking the patient's own blood that has been drained from the chest, filtering it, and then transfusing it back into the patient's vascular system. In such an emergency, anything may be used that is large enough to fill the chest wound. A towel, a handkerchief, or the heel of the hand. If conscious, the patient is instructed to inhale and strain against the closed glottis. This action assists in re-expanding the lung and ejecting the air from the thorax. In the hospital, the opening is plugged by sealing it with gauze impregnated with petroleum. A pressure dressing is applied. Usually, a chest tube is connected to water seal drainage is inserted to permit air and fluid to drain. Antibiotics usually are prescribed to combat infection from contamination. The severity of open pneumothorax depends on the amount and rate of thoracic bleeding and the amount of air in the pleural space. The pleural cavity can be decompressed by needle aspiration, thoracentesis, or chest tube drainage of the blood and air. The lung is then able to re-expand and resume the function of gas exchange. As a rule of thumb, the chest wall is opened surgically, thoracotomy, when more than 1500 ml of blood is aspirated initially by thoracentesis, or is the initial chest tube output, or when chest tube output continues at greater than 200 ml per hour. The urgency with which the blood must be removed is determined by the respiratory compromise. An emergency thoracotomy may also be performed in the emergency department if there is suggested cardiovascular injury secondary to chest or penetrating trauma. Tension pneumothorax. A tension pneumothorax occurs when air is drawn into the pleural space from a lacerated lung or through a small hole in the chest wall. It may be a complication of other types of pneumothorax. In contrast to open pneumothorax, the air that enters the chest cavity with each inspiration is trapped. It cannot be expelled during expiration through the air passages or the hole in the chest wall. In effect, a one-way valve or ball valve mechanism occurs where air enters through the pleural space but cannot escape. With each breath, tension, positive pressure is increased within the affected pleural space. This causes the lung to collapse and the heart. The great vessels and the trachea is shifted toward the unaffected side. of the chest, mediastinal shift. Both respiration and circulatory function are compromised because of the increased intrathoracic pressure. The increased intrathoracic pressure decreases venous return to the heart, causing decreased cardiac output and impairment of peripheral circulation. In extreme cases, the pulse may be undetectable. This is known as pulseless electrical activity. Clinical manifestations. Clinical picture: the air hunger, agitation, increasing hypoxemia, central cyanosis, hypotension, tachycardia, and profuse diaphoresis. Medical management. If a tension pneumothorax is suspected, the patient should immediately be given a high concentration of supplemental oxygen to treat the hypoxemia, and pulse oximetry should be used to monitor oxygen saturation. In an emergency situation, a tension pneumothorax can be decompressed or quickly converted to a simple pneumothorax by inserting a large bore needle 14 gauge at the second intercostal space, mid-clavicular line of the affected side. This relieves the pressure and vents the positive pressure to the external environment. A chest tube is then inserted and connected to suction to remove the remaining air and fluid, re-establish the negative pressure, and re-expand the lung. If the lung re-expands, the air leakage from the lung parenchyma stops. Further drainage may be necessary. If a prolonged air leak continues, despite chest tube drainage to underwater seal, surgery may be necessary to close the leak. Thank you.